I wanted to ask how, when we were having a conversation earlier, you mentioned injections, right? How are injections given while, you're doing the imaging?
So this is my interventional part of work. Yeah?
Okay.
So in musculoskeletal radiology, intervention is the very, very important part.
Yeah.
And these days, they improve the diagnostic accuracy because a lot of injections they can treat the inflammation in the body, they can treat the condition, they can treat the symptoms and delay the patient needing any more treatment. So this is musculoskeletal world where injections are very, very common, and these are usually done by image guidance, in which ultrasound is the main workhorse.
Okay.
And ultrasound guided interventions are very, very common. For example, in the shoulder, in wrist, knee joint, hip joint, we do ultrasound guided. There are three modalities by which we usually do intervention, which is ultrasound, fluoroscopy, and CT scan guidance.
Okay.
So CT scan guidance can be done under either X-ray guidance, which is fluoroscopy, or CT scan in the spine. But my preference is usually CT scan guidance. So I do with CT, so I can be more accurate in all the three planes.
Okay.
And that's what I do. But for shoulders and elbow, wrist, I usually use ultrasound.
Okay.
And that improves because you are looking and watching the needle, and you are putting in somebody's body, so you know exactly with precise location from your knowledge, because when we do ultrasound, usually the patient had an MRI done, and the diagnosis is already made. But ultrasound also, we confirm the diagnosis. I talk to the patient there and then, is it hurting there? And then I put the medicine in the correct place, and the accuracy can be up to the millimeter. So that's where it works the best, because if you are putting an injection around the tendon, it's a very small area and you have to put it in the correct tissue plane, because if you put that in, say, 2 millimeter different, the patient outcome is going to be very, very different. And second thing is, there are normal structures inside the body. So if you put in the wrong place, if you put inside the tendon, actually you can potentially harm the patient, because the tendon can rupture. So that is how it's very, very important to be in the correct place. And I was talking to you about the spinal injections where somebody has disc bulge. And
so it's called nerve
root impingement.
Yes. My mom had it.
Yes. So it can happen in the lower back, or it can happen in the neck. So if a nerve is getting compressed because of the disc, that nerve might be swollen. And the purposes of these injections is to reduce the swelling and to reduce the inflammation. I mean, common word, we use swelling, but that's actually the inflammation in medical language. So we go inside there, go into the nerve root sheath and inject the medicine, so that the patient get immediate relief. We get some local anesthetic along with that as well. And that's where it has to be that precise, because you cannot put the medicine like millimeter away or millimeter deep inside the nerve, because if you put inside the nerve, it will be excruciatingly painful. So you have to be very accurate. And that is where, if you are away from it, the patient is not going to get better. So that's where it's the preciseness of it increases significantly with imaging. And as I mentioned, that patients are very well informed about this as well. So they come asking for image guided interventions. So these days, technically, I would say that 95% of the interventions in UK are done by image guidance. Only very few in very common locations can be done clinically guided, but usually it's patient choice as well. And there is evidence behind it that image guided interventions are much far superior outcomes. That's why they are performed.
And how long does this treatment last? Like if you give an injection, like, I don't know, nerve root, how long does it last? Is it like a specific time, 6 months, 1 year, or like it depends on the patient and their condition?
So this is a very interesting question, because this is a question which is commonly asked to us. And a lot of patients will ask us this question. So I'll tell you one example. Like when I report a lot of scans, as you asked earlier on, that I find different findings. And the interesting thing is, like, not all of these findings are causing symptoms to the patient. So as we grow old, as we have even not necessarily old, like our body changes, and our body will have something or the other which is a variant of normal. Like if you scan 10 patients who are, or 100 patients who are going on the road, and some of them will have some sort of disc problem, on the scan, but necessarily not that everybody has got symptoms. Only probably 10% of them might have symptoms. So it should match, like symptoms and findings should match. If they do not match, then you do not need any treatment. So it depends on the grade of severity. Your question was like, how long does it last? So depending on, for example, your knee joint injection, if we do, and knee joint is completely worn out, and at that stage, it may not last very long. I'm being honest, because at that stage, probably when it reached to bone on bone joint, there is no cartilage left. In that stage, you might end up having a new knee or artificial knee replacement. But it's very efficacious in the early stages, in the moderate stages as well. And it's very useful for buying time when you're waiting for the surgery. So, and sometimes it makes your acute symptoms as non-acute. So like, your symptoms will settle down. For example, my father is 76 and he has got very worn out knee, but he's not in pain. And I gave him injection 4 years ago. And I wouldn't say that everything is down to that injection, that he's symptom free. I would say that sometimes the acute symptoms settle down and then they are back to normal. So a lot of patients get interventional procedure done when they are in too much excruciating pain. Then they go back to physiotherapist, they strengthen the muscle, they get the time, because that's the time, pain-free time. They do rehabilitation and then they don't need anything for a time, for a while. So it's all about putting the patient back on track, because those age-related changes and degenerative changes will keep on happening. That doesn't mean we are treating each and everything in the body. We only treat what is needed.
So a quick personal question. So I mentioned my mom had that issue, right? So she was absolutely fine one day and then this thing happened. Once she started having the nerve root injection, I think she had like 3 or 4 of them. And then the doctor said, we can't give you more. But after those injections, she felt a lot better. The pain was, I would say, just 90% gone. And she was, walking, going out, and doing, most of the stuff which she was doing before the problem. But what I want to ask is that, is there a chance that she had this problem at the back end but no symptoms? And then one day something happened and it got triggered? Does that happen?
Yes, exactly. So that is a typical history which patient give as well. Like they lifted a heavy weight or something and suddenly the pain started. Or they were moving the house or something happened. And that's where the disc bulge came. And as you mentioned that your mom thankfully had very good results. Which is which we do see in cases where there is acute history. And with these injections, sometimes the disc can shrink as well a little bit, and sometimes the swelling in the nerve root can go down, and that's how the patient get better. And when they do proper rehabilitation, as I said, the symptoms may not come back for many years, or they might be okay for good. Because even if you think about surgery, not necessarily that after every surgery patient will be completely symptom free. So the common things in medicine is always go from least intervention to severe most intervention. So like, for example, I would also recommend that first you should try physiotherapy. Everybody should try for any musculoskeletal conditions. Try physio, yoga, those type of things if that is possible. If that is not working, it is not bad to take some anti-inflammatory medications. If still that's not working and you think that it's affecting your activities of daily life and you cannot manage for 3 to 6 months, then you can consider at that stage having injection. If that helps, very good. If it doesn't help, possibly you go back to your doctors and consider having reassessment and another repeat injection. And then comes the surgery. So like surgeons are also very keen not to do unnecessary surgeries because they want good results from the patient and to make the patient better. As I said, we all want to, we are working towards the patient to improve their life, to improve their satisfaction, and to do a good job at the end of the day. That's why we all are in this profession. So that is really important.
I remember when my mom was diagnosed, before that was a different story, but once she was diagnosed and her doctors were really good, like they they did mention that surgery is the last option. And they did tell her that, because I remember I was there, that, they do this very common every day.
Yeah.
It's fine, but there's, still a chance that because it was near the spine, right? So they were like, there's always a chance of problems or things not going the way the doctors want. But and I think it's really important for a doctor to actually make the patient comfortable and make them aware of all the options. So then the patient can obviously with doctors' recommendations take the right decision, whatever they want to go ahead
Exactly.
with. Yeah.
So this is called like making patient the partner in making a decision. So it's called informed consent. So we do give them options, and the clinicians who are looking after the patient, they will give them the options.
Yeah.
And most of the patient do listen to the doctors and the consultants who are looking, because in UK, I would say that it's really good culture, that there is a trust culture as well. And that's, I would say that we are very thankful we had NHS in this country. NHS had a very good reputation and have a very good reputation in treating the patient correctly.
Yeah.
And one thing which I learned in this country, I would say I'm extremely thankful to this country's medical culture, that one thing was very initially taught in my career, that if you cannot help the patient, at least do not harm the patient.
Yeah.
And that is something which I took to my heart, and every day I follow that.
But that is also helping the patient.
Exactly.
Yeah.
And it's like, it's a humble thing. I mean, if something is not in my hands or I do not have the expertise, it's very, we openly tell to the patient that please go and see my colleague. And that's a kindness, like that you should not touch something which you are not expert in.
Yeah.